It's the long lever for the talocalcaneal joint. So you're going to literally place the heel here, and you need to do a degree of dorsiflexion, okay? And then use the weight of the leg to create a little bit of traction, and your movement will be this. So you're doing circles with your elbows. Stay close to the patient, ideally more in this position here. So if you want to lean on the couch, some of you will want to lean here, okay? Your choice, okay? I don't do it. If you're going to lean here, just be careful that you're not creating compression, because otherwise the traction that you do on the calcaneus doesn't make sense. So if you're going to lean in too much, okay, you are undoing what your hand's trying to do here, okay? Like with any long lever leg techniques, if your patient has hyperextended knees, be mindful. Here in class, usually you guys get away with it. If you're doing it with patients in clinic, you might sometimes be able to do the technique, but for a short period of time. You can't stay there too long, because otherwise you are posteriorizing the tibia and it gets uncomfortable on the patient's knee. Okay, so it's one of those where it's a very good technique to do, depending on the needs of the patient, not so good. And then we're going to do that one. It's a subtalar traction technique, okay, which there's two ways of doing it. Patient is supine, so head this way now. And what we're going to do is create a triangle to create the traction, to basically bring the talus, either the talus away from tibia fibula or calcaneus navicular away from talus in a way. Okay? So if we do it as a talocrural, for this one I would say practice it first as a talocrural joint. Once you're comfortable with it, then move to subtalar. Technique is the same, but because your hand position will be slightly lower, it's a bit trickier to feel the tension. So for now, practice it as a talocrural. So the patient is supine, and here you're going to use the fact that you're going to basically need to have your forearm longer than your patient's leg. Okay? Which for some of you is easy because you already have long arms. So then your technique becomes easy. If your arms are shorter than the patient's leg, I now need to find a way of relatively lengthening my forearm, because the technique, you'll be here, you're going to place calcaneus on your hand, reinforce talus, okay? And the technique is to take the talus from here to here. And this little shift here decompresses the talocrural joint. Once you've achieved that traction, here you circumduct. And you're going to get some serious level of grinding and crunching in here. Okay? Because this is the joint that has quite a lot of the compression loading. So to decompress, you don't need a lot of movement. It's just a little bit. You can have your hands in this position, doesn't matter. Okay? But create a nice support for calcaneus. And you're literally imagining you're bringing calcaneus talus away from tibia fibula. But the movement is here. So if you don't have the triangle, technique doesn't work. What you end up doing is tractioning this way, and you're actually gapping the knee joint. Yeah? Now, some of you are not going to like this position. You're going to say, my back hurts, my legs are too long, or I'm in an awkward position, or whatever. Yeah? So there's another version, which in my opinion is even more awkward. Yeah? But I'll show it anyway, you don't get embarrassed anymore. You're sitting between the patient's legs. And now you have the patient leg here, and you're going to use, this position here. Still same principle of technique, okay? You're literally now just sitting between your patient's legs. But some of you prefer it because you're sitting, okay? You're not leaning forwards. it's a matter of choices. It also depends on your patient. If you think it's a patient that will be comfortable with that, nothing wrong with the technique. If you think your patient is a bit more shy or a bit more awkward, or if you are very tall compared to the size of your patients, don't do it. Yeah, there are other techniques that you could use instead. Okay, but they're actually very good traction techniques. Well, don't look for a lot of range of movement. Okay, but it's just a little bit of decompression. If you can make it specific, it's a very, very good technique to use. Particularly patients with like more degenerative changes, like they're starting with osteoarthritis of the ankle, they'll really benefit from this. Or patients that tend to do sports or activities that require a lot of high impact onto that ankle. Yeah? Could I have a model, please? I found the other leg. I keep putting them on the pillow after showing the techniques. So for the first one, could you come a little bit closer? Thank you. No, still fit on the couch. Oh. Yeah, thank you. Just so I don't have to lean forward so much. So for the first one, it's just for the talococcneal. So make sure you place just calcaneus in your hand, okay, and bring some traction here, so a degree of dorsiflexion, and you stay low enough so that you're rough head level of the sternum, and you're here, and then you just mobilize, and you can go looking where the barrier is. It could be more in inversion or more in eversion. For most of you, I think you guys need to work in eversion, but most of you spread your ankles too much. Okay, and you can come here and challenge the barrier. Okay, so I don't want to see if you're doing this, there's no focus. Yeah, because you're moving everything. Just a little bit of traction, small, slow circles against the barrier. So you want to nudge that motion barrier. Yeah? For the other ones, I need to be on this side. Yep. So I will need you to shuffle up a little bit. Thank you. So, place here, but, okay, I now need to make my arm longer. So the way to do that is to change the angle of my leg. So if I stay more oblique, now when I'm going to place my elbow here, my arm is now longer than the leg. Okay? So don't stay too high on the femur. I also cheat because I do a little bit of external rotation and I use my ribs to stabilize the leg so it doesn't rotate. You might not need to do that, okay? But I find it just stabilizes a little bit more. And that should be okay on your leg.
Yeah. Fine.
Then position here, and you've created a shelf for talus. The other hand comes on top, and then when you're here, you just go oblique. So you go from here to here. That causes a traction. Once you have traction, you circumduct and come back. Traction again and circumduct. If you lose a triangle, see here, I have nothing. When that traction is going everywhere. Okay, so you need to have that fulcrum from here to here. Okay? To make it more comfortable on your back, if you notice, my leg is bent, so almost kind of sat on my leg. So this way, when I curve forwards, I'm not putting my back into stress. If you stay like this here and try to do this, then you're going to be sore. So soften up the other leg and lean against the couch. You'll be a lot more braced for the technique. But I agree, for some of you, this is going to be horrible on your back and you're not going to like it. Okay? It's just, you can't always modify it. I'll do the other one. The problem with this one is this. I can't see my patient. Yeah? And other than the fact that you're sat between the legs, but you know. And here you need to, because the thing is, you need to have your iliac crest behind the knee. So if you stay far from the patient, and I'm doing this here, look, okay? I'm losing everything, knee and hip. So if I don't want to lose the movement, I need to be really behind the knee and like this here. So that now, when I'm doing the technique, I have more traction. And I'm not losing everything in the pose. You could, some people do it. Here. I think that's how David Kennett used to show it. This way here. There. Okay? So you might find it a bit easier to stabilize the patient. I find this more awkward because I feel I don't have enough fulcrum on the leg. So I feel I don't do as much traction as when I come this way, okay? But then I'm small, so I don't have the problem of being over my patient. But this one I never use. I always, the other one though, I really like it. It seems uncomfortable, but actually, for patients who have very chronic compressed ankles, it's probably one of the best techniques you can do if you don't want to put your patient prone. Yeah, it just takes a little bit of getting used to, but honestly, if you're close enough to the couch and your legs are softened up, bent, your back, you learn to kind of to brace without actually straining your back. But at the beginning, you're not going to like it. Very few of you do. It's one of those that tends to grow on you. Okay? And when you have small arms, you really need to go oblique with your leg, because you can't make your arm physically longer. Yeah? Try those. For this one, you really need to sort out the couch height. Otherwise, there is no way of making this comfortable. Yeah? So you need to play with different settings. Yeah?